So if we think about somebody laying face down, they have that cervical lordosis, it kind of bends forward, then the thoracic kyphosis, like a little hill, and then the lumbar lordosis, like a little hammock, right? I put the blood in the hammock, down in the lumbar spine, it's just going to pool there. Turns out if you put it at the top of the thoracic spine, it really spreads a lot for even a smaller amount of volume. And almost all the leak types tend to occur in the thoracic spine.
Welcome back, every Bendy Body, to the Bendy Bodies podcast. I'm your host, Dr. Linda Bluestein, the Hypermobility MD, a Mayo Clinic-trained physician dedicated to helping you navigate EDS and complex chronic illness. Today, I'm joined by Dr. Dacre Knight, who is not only an expert in EDS, HSD, POTS, and mast cell disorders, but is also joining me as a recurring co-host. Dr. Knight recently became the medical director of the UVA Health EDS and Hypermobility Disorders Center, which is officially partnering with Bendy Bodies. I am so excited to have this conversation today with neuroradiologist Dr. Andrew Callen. In people with connective tissue disorders, CSF leaks or cerebral spinal fluid leaks are so much more common than most people realize. People can suffer for years, if not decades, before getting appropriately treated, so this is a really important conversation today. Dr. Callen is an associate professor of radiology and neurology at the University of Colorado School of Medicine and the founder and director of the CU CSF Leak program, Colorado's first multidisciplinary center dedicated to diagnosing and treating spinal CSF leaks. A national and international leader in this field, he has authored over 60 manuscripts, including more than 30 peer-reviewed publications and 2 textbook chapters on CSF dynamics and spinal CSF leaks. He is also the inventor of a novel patient positioning device for dynamic CT myelography that improves diagnostic accuracy. Dr. Callen is a founding member of the International Spinal CSF Leak Society and serves on medical advisory boards for U.S. and Canadian CSF Leak foundations. I'm so excited about this conversation and can't wait for you to learn from Dr. Callen. As always, this information is for educational purposes only, and it's not a substitute for personalized medical advice. Stick around until the very end so you don't miss any of our special hypermobility hacks. Here we go. Well, I am so excited to be here with Dr. Andrew Callen. I've been wanting to talk to you for such a long time, so thank you so much for coming on Bendy Bodies.
Thank you for having me. Yeah, it's my pleasure.
Fantastic. So we know that CSF leaks are something that are really common in this, well, they're more common, I should say, in people with connective tissue disorders. And let's just start out by, if you could explain what CSF leaks are and why people can get things like spontaneous intracranial hypotension.
Sure. Yeah. Just starting from basics, just a definition of terms. CSF stands for cerebrospinal fluid. It is the fluid, a clear fluid, looks like water, surrounding the brain and spinal cord. And it's contained by the Dura, which is the sort of sacral lining that holds that fluid in. And it participates not only in sort of a cushioning or sort of just a mechanical barrier or presence, but also it's very important in the sort of metabolic function of the brain, and many other sort of processes that are being actively investigated currently. And doctors have known for a long time that if we put a needle in someone's back, for example, to do a spinal tap, a lumbar puncture, and take fluid out, that people may get a headache and associated other symptoms. But really, in the more recent sort of understanding has emerged that these leaks can occur spontaneously. And when we say spontaneously, we mean that there wasn't an obvious precipitating cause. But, some people, a little less than half, around 40% of patients, will experience some sort of very minor trauma. For example, they fell down or they bumped their head or what have you. But nonetheless, we call these spontaneous rather than traumatic, which can have its own sort of distinct appearance. And when they occur, they occur in 3 major forms. The first form is when there's a little bone spur in the spine from wear and tear arthritis that will poke a hole in the dura, usually in the front of the dura. And that then fluid comes out. We see a big fluid collection in the spine. The second is on the side of the spine, the spinal cord gives off nerve roots. Those nerve roots are branch points from the dura, and they can tear. And it's these types in particular that seem to be most associated with connective tissue disease. They tend to occur in the lower thoracic spine mostly. And these are, while it seems like, it's a hole and fluid comes out, that should be straightforward as well. I've also sort of undergone a renaissance in understanding, which we can get into in more detail later. But nonetheless, another tear in the dura, fluid comes out. And then in 2013 and 2014, a third type of CSF leak was discovered, which is a CSF-venous fistula. This is not a hole in the dura with fluid pouring out, but rather a vein, a normal vein, that is participating in normal physiologic CSF resorption every day, that loses that sort of regulatory capacity, and the fluid just sort of gets drained through this vein unchecked. And so the CSF is being lost, but into the bloodstream. And so there's no fluid collection. A regular myelogram where we inject X-ray dye into the spine, the test that's done in almost every hospital in the country, will not find it. You have to do a very special type of myelogram. That was part of the reason we couldn't find them. And so, and then it basically will result in this syndrome where we have, it's classically characterized as a so-called orthostatic headache, a headache that is worse when we are upright and better when we are flat. But that too has undergone a really big revolution in terms of understanding the symptom complex of this disease. It's really much more complicated than that. I can't tell you how many of my patients say, Dr. Callen, it's not a headache. It's not. It's a different feeling. It's a sensation. There's other things going on with it. Some people have no headache at all. And particularly with that CSF venous fistula subtype, it could be very, very, you might say atypical. But to me, what's atypical is really that just basic classic story, right? And we're just learning more and more about the different ways that these patients can present. And it makes it really challenging because this is not the sort of paradigm that we as doctors learn about in med school, right? We just say, oh, it's a headache, and that's it.
For sure. I'm an anesthesiologist, so I learned about, you do a wet tap or you do a spinal for doing a subarachnoid block. And yes, you may get a CSF leak headache, and then you might do a blood patch, but it was like a very straightforward thing, right? And so spontaneous CSF leaks are definitely something that I had not been aware of at all before. They're so often overlooked. They're so often misdiagnosed. I know that, normal imaging, quote, normal imaging is also a huge part of the problem. Can you explain more about why these are so often overlooked and misdiagnosed? And we're going to get more later into like what people should do if they really strongly suspect that they have a leak and they have normal imaging. But what kind of symptoms should we be looking for that don't fit the classic patterns?
Yeah. There's a lot of great stuff to talk about in that question. I just want to briefly touch on the fact that, we're talking about spontaneous CSF leaks today, but, half my patients are people suffering from chronic doctor-caused leaks. This is another thing that we've come to understand. Certainly as an anesthesiologist, but as a proceduralist, like, in neuroradiology, I was certainly taught this is a benign self-limiting thing. Post-stroke puncture headache, have them lay down, drink some caffeine, they'll be fine. We now know by a relatively robust body of evidence that this could become a chronic debilitating disease as well. So I feel very strongly about that requires more recognition as well. But in terms of why, why this is overlooked, I mean, you could start. There's so many ways to look at this. I mean, the first is probably the clinical recognition, right? If somebody does not come in and say, "Hey, I have a headache that is horrible when I stand up. It's in the back of my head, and it's like a pressure sensation. And then when I lay down, it goes away." If they don't say that sentence, then they probably will not get cued by their doctor to be like, "Oh, could this be a CSF leak?" Right? And if they say, "Well, when I first started, I noticed that, but as it went on, actually, when I laid down, I didn't get as much relief as I did, and that part went away." Or they're describing vestibulocochlear symptoms. This is a very common set of symptoms that go along with a spinal CSF leak. And what I mean by that is ringing in the ears, a sense of imbalance. Patients very frequently say it's not dizziness. It's not like the room is spinning necessarily, but it's almost like I feel intoxicated or like I'm on a boat. People frequently describe oral fullness, meaning like they feel like they need to pop their ears, or it almost feels like they're underwater. They often have hearing issues, and sensory neural hearing loss, feeling like they can't understand what people are saying to them. And then along with that, cognitive, people refer to it commonly as brain fog, cognitive slowing, sort of just feeling like they're not themselves. They can't do their normal activities of daily living, balance their checkbook or just talk to people without, they struggle to find the correct words, etc. And these sets of symptoms, and they go on and on and on. The problem is that they're not specific for this disease, right? So it's, really, it's. I tell my patients, if you talked to me 5 years ago, I would have been much more certain about things, right? They would say, I have this symptom. Could that be my leak? And I would say, well, no, 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 that's not a leak. And then we would treat their CSF leak and it would go away. And I would say, wow, what do I know about this? And really, there's not like a specific clinical question I can ask a patient and say, aha, that therefore it is or is not a leak. And that's why we rely so much on the imaging.
Yeah, that's so tricky because we know that this same population of people are at risk for Chiari malformation, dysautonomia, craniocervical instability, like so many things, elevated intracranial pressure, which obviously is like the opposite. But it seems like that's so tricky because they probably get mislabeled super commonly. So yeah, it would be nice if we had really highly specific things to be looking for.
Yeah, absolutely. And I think, patients find themselves, my patients, our patients, we're talking about, find themselves in this area of medicine where there is so much uncertainty, and doctors don't like being uncertain and they don't like not knowing. And so what the frequent response to that is dismissal of symptoms. But really, if where that leaves patients is struggling to figure this out on their own, which often can lead to, you know, inappropriate or just sort of over the top test treatments, things, spending money, et cetera, when really they just need somebody to listen to them and just go through the story very, very carefully. You mentioned earlier the concept of the normal brain MRI. It's funny, a lot of the data and literature about, a certain percentage of patients have a normal brain MRI. Well, I can't tell you how many of my patients we see, um, they are, come from an outside institution. We get their imaging reports, and the report says a normal brain MRI, but it's not normal. There are subtle features of intracranial hypotension that were missed or overlooked, and so that person is getting lumped in with this so-called normal statistic, right? And there is sort of a newer, increased understanding of radiology that it's not just one finding or two findings, all these different findings. We have to look at them very carefully, but uh, you know, it requires a very careful eye and a systematic approach and education on the imaging side as well.
And before Dr. Knight jumps in with some questions about leak types, you've already explained a little bit about that, and some red flags. Can you first just comment on opening pressures and if they are usually low, or could they be normal or even elevated?
Yeah, this is a huge problem in this disease. We just make a list of issues. In the International Classification of Headache Disorders, one of the major criteria for the diagnosis of intracranial hypotension is a low opening pressure. Um, However, study after study has shown, including some of our own work, that the vast majority of patients with this proven spinal CSF leak do not have a low opening pressure. This is a big problem because as you can imagine, some patient in the community, they go to their doctor, their primary care doctor, their neurologist. They describe symptoms, and perhaps that doctor says, "Oh, this could be a CSF leak. Let me measure your opening pressure." So they perform a lumbar puncture with a cutting tip spinal needle that's probably very big, and they measure the pressure. It is not low, so they say, "Well, you do not have intracranial hypotension," and now they've exposed them to the risk of post-stroke puncture headache. And so this is a something that needs to be changed. We've been advocating for this for a long time, but it's embedded in the name, hypotension. It should be low pressure, right? But really, this is not a disease of low pressure. It's a disease of low volume, and the intimate interplay between the epidural venous plexus, which surrounds the dura, and changes in its dynamics, which modify the pressure in the spine. And when you mentioned earlier, then there's people with high pressure, but that's a different thing. We're starting to understand that these diseases are probably more similar than they are, disparate diagnoses. But instead, for example, one of the leading hypotheses in why CSF-venous fistulas form is that these people may actually be living with higher pressure before and develop the fistula as sort of a release valve, if you will. And this is, evidenced by the fact that really almost everybody with a CSF venous fistula does not have a low opening pressure. It's very unusual to have a opening pressure below 6 or what have you with a CSF venous fistula. And so it's often even higher or elevated above the normal range. So this is a big misconception. I would, if a patient is going to undergo myelography, dynamic myelography to have a leak, searched for, and there's going to be a needle there already, of course, measure the pressure, right? It's additional data, and sure, if it's very, very low, then that's confirmatory. But I would say there's almost no circumstance in which I would advocate for the measurement of opening pressure in isolation, performing a lumbar puncture for that purpose alone.
And Dr. Knight's going to ask you some questions about leak types and red flags.
Yeah, thanks, Dr. Callen. I've already learned so much, I feel like, and I did have a couple questions in mind, but I feel like I've just doubled the number of questions I have now I want to ask because there's so much, and I'm learning a lot. So thank you greatly. But I guess, like you started from the basics. I just want to go back to the basics too. Again, just first, you mentioned the word Dura a couple times. Can you just explain to us what that is and what's the importance of that here in these situations?
Sure. So yeah, I mean, Dura means strong. It's the Dura mater, the strong mother. That's the outside tough lining of the sac that's holding that fluid in. Under it, is the arachnoid layer, and just like it sounds like spider, right? Well, it's because it kind of looks like a spider web, and so you have these are the layers of the meninges, the layers that contain this sort of subarachnoid space where the CSF, the brain, the spinal cord live. And so it's important to understand those layers because there are, I mentioned we've had an increased understanding in that lateral tear type that people with connective tissue disease we think are more susceptible to. There can be herniation of the arachnoid layer through the dural tear with that leak type. And if you're not careful, you could just look at that and say, well, that's just a normal nerve root sleeve, or it's meningeal diverticulum, when in reality, it's a hernia from the inner layer out to the outside. So understanding the anatomy of these layers, not just in the fact that that's the barrier that's holding the fluid in, but how they can interact, how they can manifest pathophysiologically in the context of a leak is really important to not missing something that's right there in front of you.
Yeah, I think so. And thanks for explaining that. So, because in my mind, sometimes I think of it as maybe we're describing this as like a water balloon, right? We've got a thin layer containing fluid, but it is really more than that because there are multiple layers too. And yet it may still be fragile like a water balloon, right? You're saying there's a tear and it's a leak, but it doesn't rupture exactly. But yeah, thank you for that explanation. I think that's important to understand that we're talking about multiple layers and still some of these same risks that come up. And you did mention about the types of leaks, and you just refer back to the tears. And then I was interested in also about the symptoms too. So just to kind of hone in on that a little bit, um, are there some? Certainly, there's a lot of overlap and a lot of things that can mask other things, and that makes it very difficult. But my first question: are there some things that are like hands down? This is a CSF issue. Like this is a red flag. This is something that's clearly there.
Uh, you know, I wish I could say, well, certainly there are red flags, right? So yes, if somebody has a sudden onset, new daily persistent headache, um, this is not generally something that it's like one day a week I have a really bad headache or migraine, for example, or 2 days a week, or even 3 days a week. This is usually an everyday thing, not always, but usually. Now you can have good days and bad days, but you're generally not normal in between days of having this. A new sudden onset, continuous, and we still describe it, orthostatic or positional headache. Now, I sort of think that word is very interesting because I have a lot of patients who say, I'm actually okay when I'm upright. And so particularly with CSF-venous fistulas, we wrote a paper about this, talking about the symptom complex in patients with that leak type. We'll say, it's not being upright. It's going from laying to standing, or laying to sitting, or sitting to standing. This I feel unsteady. I feel head pain, neck pain. I have ringing in my ears. Then once I stay on there for a couple minutes, I'm okay. Or when they turn their head very quickly to look side to side, for example, this could make the symptoms come on. Now, is this a positional headache? Sure, they're changing position, but it's not the way I think that we think about this, right? So, um, in general, to me, somebody who has a sudden onset, continuous, um, positional, however you want to interpret that, headache associated with those vestibulocochlear symptoms, dizziness, ringing in the ears, oral fullness, some sort of, feeling cognitively slow. Um, that will, I'm very, very suspicious that they have a CSF leak. But, the problem is, like, as you mentioned, there is overlap, for example, with dysautonomia. This umbrella term that encompasses a wide host of diseases that need much more understanding as well.
You read my mind. Yeah. I was going to ask exactly about that.
And so it's really, it's really the most important thing you can do is, do things that are non-invasive up front, right? So we can obtain an MRI, even without contrast if a patient's worried about that, like, for example, in a young person, and get MRIs of the brain and spine and start there and do non-invasive things, evaluate our pretest probability. Have we really ruled out that it's a primary headache disorder? Have we looked into the dysautonomia component? If it's not obvious, and it's staring at us obvious, from the imaging, of course, we'll go down gangbusters down that road, and combine that with the clinical story to sort of decide on next steps. Because I have patients who come in and they tell me exactly what I just said to you, all those things, a perfect story for a CSF leak, and we look everywhere and we try everything, and there's nothing. And then I have patients who come in and say, "There's actually nothing wrong with me." And their spouse is with them and says, "Well, no, there is. They've been really weird. They've had a personality change. They have no headache, no vestibulocochlear symptom, nothing. And they have a huge CSF leak." And it's, there's no perfect heuristic for sort of how to parse apart these things based on clinical questions alone, at least not yet.
Yeah. You have to use your judgment, right? You have to pick up all the clues you possibly can. So, yeah, thank you for that explanation. I I agree. I think that's what it comes down to. Is it like, look at the pretest probability, and let's not just like, get this analysis paralysis. We can actually take the next step and do the testing if it's warranted, and as long as it's not so expensive, so invasive, we can do some testing for POTS easy enough, and we can do some testing for CSF leaks. And that's actually what I want to turn my next couple of questions to, is a little bit more about the testing, some specifics on that. I guess the first one then is, so you mentioned the myelography, right? So that in the brain MRI. Now, so I want to ask about those. Let's maybe start with the brain MRI first. You mentioned that previously there were some things that you could pick up on a brain MRI, even if the report says it was normal. What are some of those things that you might look for?
Yeah, I think talking about the brain MRI and myelographies together is really important, because I think it's a good way of framing both things, both tests. So when a CSF leak occurs, there are two parallel pathophysiologic um, mechanisms that can manifest on imaging. One is the brain sag, right? So easy enough to sort of conceptualize, I think. There's a boat floating in water, the water level's going down, the boat's going down, the brain will go down. Now, there's a big problem with this, with the Chiari diagnosis, right? So when the brain sinks downward, the cerebellum, which is at the very bottom of the brain, its tonsils, the bottom, will sometimes protrude through the bottom of the skull, the foramen magnum. This will sometimes get misdiagnosed as a Chiari deformity, um, because that disease also can have the cerebellar tonsils too low, but that is a completely different mechanism. In a Chiari deformity, the skull is too small for the back of the brain. And notice I'm using the word deformity, not malformation, which is commonly used. This is the sort of newly accepted term, because you can sort of acquire this in terms of the development of your skull over time. And you're not born with it necessarily at birth, as would be called, but with a deformity. But nonetheless, you have two ways that the tonsils can be too low. One is because the skull is too small and it's squishing the brain out. And the other is because the brain is sinking down, right? So we have to make sure that we're looking at SAG, not a Chiari. And then we're looking at other sort of parts of the brain that are also slumping downward. And we measure little intervals around the brainstem and above the pituitary gland. And we measure those intervals to contribute to what's called the Bern score. Okay. Um, Let me talk about the other sets of things that show up on the brain MRI. Then I'll put that all together with the Bern score and show how that ties to myelography. So we talked about brain sag. The other set of findings relates to this doctrine that we learn about in medical school called the Monroe-Kelly doctrine, that inside this craniospinal compartment, this is a fixed compartment. that consists of brain, blood, and CSF. And if one leaves or changes or increases, the others will change to accommodate that. And so the blood-filled structures will engorge to take up the space lost by the CSF. So the dura itself, which is venous rich, will thicken. You'll get pachymeningeal, another word for dural, thickening. The pituitary gland will engorge. The dural venous sinuses will engorge. But patients don't have to have all of these findings at once. They could just have one of the findings, be very subtle. They could have none of the findings, or after you treat them, you see, oh, they did have very, very subtle brain sag. And now that I see that it pop back up, it's that is what it was, or it could be very dramatic. And the reason that we put these together, these observations of narrowing of distances for sag, the observations of engorgement for the von Rotelli doctrine, and we put them, we calculate this Bern score, which is a probabilistic scoring system that reflects how likely it is that I will find your CSF leak on a myelogram. Now, this is very important. It seems like, sure, that's the same thing as having a leak. No, it is a reflection of not only the state of the disease in someone's body, but it's a reflection of the sensitivity of our testing. It is so when I talk to a patient about counseling them, should we undergo dynamic myelography? I talk to them about the likelihood that I'm going to find something based on their brain MRI. It is not the likelihood that if I do an empiric blood patch on them, that they're going to feel better. But it is simply that probability. And I think that that's important when you talk to patients because, a myelogram is not the most invasive thing in the world. It's a relatively non-invasive procedure. But first of all, it's a lot of radiation. I'm often doing 4 whole spine CT scans on people. And if someone's young, I don't want to increase their risk of cancer if I don't need to. And number 2, the catch-22 of this disease that I treat is that in order to find a CSF leak, I have to put a needle through your dura. And I can essentially give you the disease that I'm trying to treat, right? And so if I have a very young person, for example, who has a Bern score of 0, there's no other explanation for their symptoms, then I might say to them, look, I think that there is probably the statistical likelihood that I will find a CSF leak is lower or equal than the chance I'm going to give you cancer in 40 years or a post-stroke puncture headache. So maybe we should start with a blood patch, for example. This is a test with no radiation, no dural puncture. Let's see, does that help you, right? So every patient's sort of care trajectory is sort of individualized. And so the brain MRI is very useful in framing the conversation in that way.
Got it. And that's very useful to hear too, how you kind of think through it in the process and in your discussion with the patients, because, every patient situation, might be a little bit different. So you kind of take this, again, the clues you can get from the brain MRI, then decide the next steps from there. So just to go into now the myelography a little bit, and you just explained a little bit what may give rise to that and why you might do that. Can you tell us how that procedure works and generally just what's your strategy on that and how you decide between maybe the different types of myelography you might do?
Yeah. So just sort of as a definition of terms and sort of to understand where we are, I alluded to this earlier, but like let's call it a conventional CT myelogram. This is not a test I ever do, okay? But this is a test done at every hospital in the country. We're injecting that X-ray dye into the CSF. Then we have the patient sort of roll around, do some yoga poses, let that dye diffuse everywhere, and then we take a picture, maybe an hour later in the CT scanner. Now that could be useful for a lot of things, but imagine there's a hole in the dura somewhere, a tiny pinpoint hole. And on the spine MRI, we see there's a fluid collection outside of where it's supposed to be. And if I do that conventional CT myelogram, I will see the dye where it's not supposed to be, matching the fluid collection. Outside, the dye is not in that big fluid collection, but I have no idea where it came from, right? So there are 2 major, I'd say, flavors of this dynamic myelography that we do for CSF leaks. The one is for the holes in the dura, a tear in the dura, right? Whether it's in the front or on the side. And what's really, really important there is our temporal resolution. So I want to be in the scanner with the patient, with their body at an angle, and injecting the dye and imaging very fast as the dye is moving down their spine to see what is that point where the dye comes out. Then I could say precisely, this is where their leak is. I could direct our treatments to that spot. And this, there are sort of technical nuances to whether we think it's in the front or on the side, the speed at which they leak, the ways that you want to image them, clues on the MRIs. But in general, that's that first family of that dynamic myelography. And the people do this in dynamic myelography in general in two different modalities. And I think patients get confused by this a lot, but there's DSM. This is digital subtraction myelography. This is the same technology and technique as when like a neurointerventionalist is treating a stroke in someone's brain. They are injecting the dye, they're taking a picture of everything, and then the computer removes everything except for the dye coming in. So you're holding the pedal down and making a movie of the dye coming in, and you can see with excellent temporal resolution where the dye comes out. For example, the same principles can be applied in the spine. We've, early preliminary evidence, and certainly my experience is that I actually prefer doing everything under CT, a CT scanner. Same concept, but I'm getting pictures back and forth very, very fast as the dye is moving down rather than holding a pedal down. And but one of the issues with doing it on the CT scanners, we need to angle the patient. And on a CT scanner, there's no angling device, whereas under DSM or fluoroscopy, the table naturally tilts. Every one of those does. So we actually, I built a table, a tilting table for my CT scanner. So I'm able to control the patient's angle. So there's this sort of winch that I turn and I can angle the patient, control that dye just so. Then for CSF-venous fistulas. So these were first identified under DSM in patients who they had brain imaging findings of a CSF leak, but no fluid collection. They were still injecting the dye and watching it, saying, "Where's it going?" And they noticed occasionally it would go into a vein, and they're like, "Well, wait a second, what is this? This is a different type of CSF leak." And we've over time, with more and more understanding, come to realize that there's a couple key principles that are very important if you want to find these CSF venous fistulas that differ from conventional CT myelography and even from the other dynamic myelography. And they are the following. These fistulas tend to come off the side of the spine where the nerve root sleeves are. So we want to get very dense contrast layering in those nerve root sleeves, not just diffused everywhere and sort of all over the place, but super dense in those nerve root sleeves. So we put a patient on their side during the myelogram. And we use very dense contrast that kind of sits at the bottom of the CSF and goes into those areas. We want to fill those nerve root sleeves. And then there's all these, that's probably the most important thing more than anything. And then there's all these other adjunctive maneuvers. We examined patients in whom we found CSF venous fistulas and sort of found that many times these can be fleeting. So it's not like it just fills a big vein and it's there and sits there and you found it, but rather it comes and goes. It's just a little wink of a thing. And if you miss it, you can imagine like you're not looking at the exact right time, then you call the exam negative. And so we will obtain more than one pass because we want to see the dye coming down early and late. Did something come and go or did it fill late? So it's that temporal part of it. There's also a component of pressurization. So I will measure the pressure as long as it is normal or low, raise that pressure with sterile water to sort of, you think about it like you're trying to pump up a tire to find the leak, right? But I want to distend those nerve root sleeves and allow that dye to penetrate. And then we do things with breathing as well. We'll have the patient take a deep breath in through a little straw. This drops the venous pressure and raises the CSF pressure. All these little adjunctive maneuvers to try to show these fistulas, which can be very shy. And so this is a real-time exam where we're in there with the patient, troubleshooting, looking at the images. Did I get dense dye over all the places? Is the quality of the exam good enough? Did I get what I needed before I get the patient off the table? It's not like a regular myelogram where it's just, see you later. Stick them in the machine, press the button, and go home. So it really is an entirely separate class of testing, despite having the same name. But it's exciting. I mean, there's nothing better than finding someone's leak on that test, and especially when it's the CSF venous fistula, in my opinion, because these patients are most frequently misunderstood.
Wow. Yeah, that's incredible.
Yeah, as you're explaining this, I'm thinking, oh my gosh, it's no wonder that some people go misdiagnosed for so long because this is so complex and you have to really, really know what you're looking for. We're going to take a quick break, and when we come back, we're going to talk more about CSF venous fistulas, and I want to know more about the targeted versus untargeted blood patch in that example that you were giving with the Bern score of 0, like how you decide where to do the blood patch. So we're going to take a quick break, and we will be right back with Dr. Callen and co-host Dr. Knight. I'm super excited to tell you about the Bendy Bodies Boutique, I am so proud of our fierce styles and flexible designs. These are created by hypermobile artists for hypermobile shoppers. There are so many fun items from clothing, accessories, home goods, and my favorite are the bags. I especially love the Weekender tote with one of the EDS Tough designs. Whether you're shopping for yourself or someone you love, there's so many options to choose from. A portion of the proceeds goes to support EDS nonprofit organizations. For more information, please visit bendybodiesboutique.com.
Yeah, thank you for all the explanation to Dr. Callen about the myelography. I think really the way you're describing it in real time is it's almost like you're painting a masterpiece of the same thing, doing sort of a scientific investigation all at once. It's so much, it's mind-boggling that what you're able to accomplish. And so in these cases of these venous fistulas, like you say, that they're maybe fleeting and things like that, I guess these are, and you mentioned too, the nerve roots and the location. These are, it's clear to me that why they are so easy to miss. Is that why it is? Because they are just kind of a little bit more hidden and just kind of a little bit, more disguised by other things around them.
Yeah, I mean, there's a number of ways that they can hide. When the first sort of pictures were coming out of these, and of course the pictures we show when we give lectures, I show these very dramatic, big CSF venous fistulas that, certainly any radiologist would look at a picture like that and say, "Wow, look at that! There's a big vein that's taking up the dye." But certainly, the more you do this, you find these very little ones. The venous network around the spine is incredibly complex. It consists of the internal epidural venous plexus that is inside the spinal canal surrounding the dura, and then the external epidural venous plexus, which is all the veins around. And particularly when it drains into the internal epidural venous plexus, it could just be a tiny little dot or line. And so you have to be looking very, very carefully. So yeah, even if you uh, have a technically successful procedure. You did all those things I said that are important to do, and it's there on your images somewhere in those thousands of images. You may still miss it if you're not very, very careful with your search pattern, with the way that you're looking for them. So there's a lot of ways that they can get missed. But even if you capture them on your pictures, you have to know where to look, not just for these big dramatic examples, but even in very small examples. And it really does blow my mind. I mean, you have, I always try to show my patients a picture of their leak after I find it. I think there's something about that, being able to visualize what's been going on in your body, both the validation that, for a lot of these patients, they've been told that nothing's wrong, but also just there's something I think that's very important in terms of the moving to the healing process about being able to see the problem. And they'll very frequently say the same thing, which is that tiny little thing did all this, right? And it's incredible. I mean, we have patients in the neuro ICU who have big subdural hemorrhages from their leak, which is something that can happen, or their brain is sagging way down. Tiny little vein that we find, right? But it's probably just the tip of the iceberg. It's draining into a vast network. We're just catching this little piece of it. But yeah, it's really something that you have to be very, very thoughtful about when you go looking for them.
Yeah, I mean, because the ramifications can be big, right? I mean, a slow leak can still cause a flat tire, I guess, right? In an analogy, you can't drive on that. So now, are there other clues that a clinician, like someone in clinic, might have to give reason for a fistula as opposed to something else, or is this is just purely just based on what you're doing?
No, so it really there's a very sort of simple distinction that we use in this. So if you suspect a CSF leak in your patient, but they do not have a fluid collection in their spine, then by definition you are suspecting a CSF venous fistula. Okay, because now there's some nuances to that. For example, depending on the way the MRI is performed of the spine, it could miss a very subtle fluid collection, particularly those lateral types. I just took care of a patient this past week where the MRI was read as normal. And until we did a CSF leak protocol MRI, you could see that fluid, but it was very hard to see on a normal one. But let's assume even with the right MRI protocol, there is no fluid, then we think it is a CSF venous fistula. And that's what we're going to go looking for. Symptom wise or clinically, I think that maybe there are some distinctions. And, I mentioned that paper we wrote looking at just our fistula patients and how they present clinically. But really, that's the key. That's where the bifurcation is there or is there not a fluid collection in this spine?
And so that leads me to thinking about another question then about, what we might be looking at in clinic, and also maybe what you might be receiving as a referral. And I know you get any number of referrals, just as I do, for a whole variety of questions. Are there some things that would make a referral better than others? Like, for example, this clinician is asking, or what they're looking for, what they've seen, what they haven't seen, and so forth.
This has sort of changed for me over the years. So, first of all, this program that we have, this clinic that we have, is unusual. It's unusual for a radiologist to be in clinic, right, talking to patients. That's not what they want to do. They want to sit in the dark room and read pictures. But when I started doing this years ago, the classic proceduralist model was you go in, you meet the patient very quickly, stick the needle in, do the thing, and walk out. And what I quickly realized is that is not the appropriate care delivery model for these patients. They have no trust in the healthcare system. Many of them, they don't understand what's going on. Their referring physician probably doesn't really either. Maybe they got them there, which was great, but maybe they've been told things that are or are not true. And so I was like, I need to have the space, not just the physical space, but that space to have that time with the patient. Sit down, take a deep breath, and say, let's go through all your everything. Let's talk about everything that's going on here, so that you are armed with this knowledge. And I know this it doesn't seem directly to answer your question, but I'm going to lead into that, which is that I really don't turn down a referral. I mean, so if unless I review the imaging, there's a big tumor in their brain that no one has seen or something, and I'm like, wait a second, you mean you have this other obvious problem that hasn't been identified. I think that even for patients in whom, and I can only imagine that you're seeing a lot of the same kind of patients that I am, you know, that are so lost, right, in this process. And even if that conversation is not going to turn into a procedure, or or if it's me saying, look, um, statistically, and based on what you're telling me, all of these different things, I wouldn't recommend going down this road if I was you or you were in my family. But still explaining it to them so they don't feel listening to them, explaining it to them, so they don't feel like, well, he just blew me off, right? They understand why. And maybe it's not that maybe I think that they might have a CSF leak, but that our current technology is not capable of helping them in a meaningful long-term way, and might hurt them, right? And so, when and very frequently we get referrals from clinicians who, are good at well-intentioned, but they just don't, they don't totally get it. And so, I don't judge them either. I'm glad that they're thinking about it. They're trying to help this person. I think that we need to be open-minded. And of course, that makes it so my wait list is longer. If I was more selective and only picked the positive people, it'd be really easy to get in, right? But I think it's important until we have a better, more widespread global understanding of this disease, and patients feel like they're being listened to and trusted, and they can trust the people that are supposed to take care of them. And when they say, I don't think we should do this, for example, it's not because they don't believe them, but it's because they do believe them and don't want them to get hurt, right? Or what have you. I think we need to be very open-minded on the front end, and just remove our preconceived notions, our misconceptions, and start from square one with somebody and say, tell me your story. Let's start from the beginning, not after the last thing you had done or the last person that told you something, but let's just start from day one, and kind of go from there.
And it certainly adds to the time and things that are needed to make it go right. But it's the way it's done right. So I couldn't agree more. And kudos to you for doing that, because not everyone really is willing to make the commitment to put in the effort. And so those that are really, it's really valuable resource. And I know those clinicians who are lucky enough to be able to refer to you are very grateful for it. So thank you. And now, in the cases as you just started alluding to it a little bit, when there are cases that would require treatments, I wanted to ask a little bit more about the treatment in more specifics. And you previously mentioned blood patching, and maybe we could talk about that a little bit more. Is there anything that you would do in a treatment situation that it would be anything more conservative than that? Or is it like, you find a leak, let's go in and let's just bang and get it done?
I mean, we could do a whole other episode just on this question, but I'll try to keep it detailed but succinct. So in general, just a definition of terms. In the beginning of this conversation, I said doctors noticed when they did a spinal tap on someone, they'd get a headache, right? Well, they also made the observation that when someone bled a little bit through that needle, but they were getting the CSF rub, that they weren't getting headaches as much. It said, well, wait a second, there's something about the blood, body's own natural healing property that can maybe fix this hole. This is where the concept of an epidural blood patch came around. And so what that means is we talked about dura, arachnoid. Epidural means outside the dura. It's a potential space between the dura and the spinal canal. So it's described to patients like it's the sheets of your bed, right? There's not a space in there until you get in there and make that space when you're going to bed. And so we are putting blood in that space around the dura. And ideally, if there is a hole in the dura, then we are trying to put that blood on or near the hole. Now, it's easy to sort of conceptualize it this way, like I'm spackling a hole in the wall, but we don't really know how blood patches work. We like to pretend we do, but we don't. I mean, we know that we need a good amount of volume, at least 20 cc's of volume. Is it because we're covering the hole, or is it because we're squeezing that bag of fluid and displacing that fluid pressure away from the hole that allows the body to heal it? We don't totally know, but we try to get it right there on there. Sometimes we'll incorporate something called fibrin glue. Fibrin glue is not glue like a super glue or Elmer's glue. It's a biosynthetic material made from recombinant components of donated human blood that makes like a super patch. Okay, so it's like it will cross-activate the clotting components in blood and make this sort of stronger patch. Again, not tons of evidence to explain that exactly. We did a study on how patches tend to spread and move, and we showed that when you combine blood and glue, they spread a little bit less, so making us think they become stronger, sort of an inference. When we have a CSF-venous fistula, a blood patch in the traditional sense, where we just kind of come from the back and put blood up and down on the side of the spine, won't almost never fix the fistula, right? You can imagine there's a vein that is coming out. Just putting blood around that isn't going to do it, right? It might make them feel better. Actually, it usually does first temporarily. When the CSF-venous fistula was discovered, at first, they would just take these people to surgery. They would say, well, let's go clip that vein or that nerve that's associated with that. And it worked very well. And then more recently, there's been sort of two other non-invasive treatment modalities that have emerged. One of them is called transvenous embolization or occlusion, where the neurointerventionalist goes into the neck or the groin, into the venous system up inside the spine to where that vein is and fills it with a liquid embolic material. And this is a very sort of elegant procedure, it can be very, very useful. And the other is what's called fibrin occlusion. Now, when these fistulas first were discovered, people would try patching them with fibrin via a transforaminal, meaning in the foramen where the nerve root comes out, where that fistula lives, putting the needle there like the same way we learned to do a steroid injection or a nerve block, and just injected the glue. And it wasn't working. And so they said, well, that can't work. But then Dr. Mamluk over in Kaiser in California, recognized, well, what if we did this under CT and we didn't just do a normal transforaminal injection, but I really tried to target where the fistula was. I just did that CT myelogram. I see it. Now it's gone by the time I'm treating it, but I know, what if I put my needle right there? And found that, we did a big study. So myself and him and several other institutions across the United States and the UK, we found that we could actually cure people. And by cure, this is very important. It means the patient telling us they're better, not the imaging got better, because the imaging can get better even if the patient's not better, about 59% of the time. Okay. But it would take sometimes 2 or more treatments to have that done. Whereas the transvenous embolization, this sounds like, well, of course it's going to fix them, right? It's right there, it's so precise. A study of 100 patients from Mayo Clinic came out about this procedure, and the patient-reported complete clinical cure rate was 58%. So within 1% of this same thing. Now, the benefit is that was after usually one procedure, right? So this is something that is hotly debated. What is the best way to go? Sometimes I tell patients, look, I quote them these statistics, and they say, I just want surgery. Are you kidding me? 58%. I'm so tired of this. I just want it to be done. And then we say, sure. Every treatment approach is individualized, in that regard. But all of these techniques are improving. Transvenous embolization, I'm sure if that study was to be repeated, now that number would be higher. I think that our numbers are higher than that now in terms of getting people better. There's more benefits and downsides to both of those modalities, kind of the nitty gritty. And when you put that onyx, that for transvenous embolization, that clotting material in, it stays in their body for the rest of their life and can cause artifacts. And we realize now that people can recur, develop another fistula. And if that happens, it's very, very challenging to find it once that artifact is there, right? So there's different sort of pros and cons to all of these, but those are the sort of general broad strokes of how we approach each leak type.
Got it. It's really fascinating to think through all of that, the potential outcomes and what may happen and looking into the statistics of it too, because obviously this is how we advance the science of it. So, and you had just touched on this, but I want to dig into that a little bit about the treatment and success versus failure, and so of course is a loaded question. We could go through a whole nother episode on this too, but in just your explanation of it, I just to hear it from you. I wanted to just ask, what does success look like for you in your practice, and maybe what are some of the reasons why you might not achieve that success?
Yeah. Yeah, this is a really important question. And so, I years ago said to myself, there's no data about how what the outcomes are after patching. How could this be, right? Um, and so we took it over several years, led 3 different studies, multi-center studies on outcomes data for patching, for percutaneous treatments of all different leak types. We're about to submit one on sacral dural tears now with a bunch of institutions. I just found it very important. Like, well, how could we not know? And I think part of the reason is because of the care delivery model that I talked about earlier. I mean, patients would get referred, maybe to Dr. Bluestein or to me. They have post-traumatic headache. We meet them for 1 second, we do the patch, and we never see them again, right? And then if they're better, we never hear from them. If they aren't, maybe we have asked to repeat it. But when you take care of these patients longer term, you start to realize that recovery is actually a very complicated and important part of a patient's spinal CSF leak journey. It is not always just one and done, and then you're back to normal. And a good way of thinking about this, you said, what does it mean for the patch to have worked? Is, I tell patients a couple things. Number one, we have the imaging part and the clinical part, right? And I need their imaging to improve and their clinical part to improve. But those don't always line up perfectly. It can often take longer for a person to feel back to normal, months or even a year, even if we were successful, but the imaging is resolved, right? So we need to stay in touch with them and make sure that they are actually feeling better. It's incredibly important if let's just focus on just the ventral dural tear, that first type of CSF leak from the bone spur that pokes the front of the dura. In that type of dural tear, in the beginning, when it starts leaking, the fluid is just sort of pouring out everywhere. We call it unorganized. It's just a fluid collection. It's just seeping out into all this potential spaces around the spine. Over time, that fluid collection becomes encapsulated, organized. It looks like it has a little wall around it. And indeed it does, we see in surgery. Once that occurs, then the chance that we are going to make that fluid collection go away with just a regular patch, we published this in the journal Radiology last year, is close to zero. It's like 4%. Okay. Now we can make them feel better, but we can't make the fluid collection go away. Now you might say, well, but we're treating the person, not the disease. Why does it matter that that there's this picture? What if they're 100% better? What if they're like, I have no symptoms anymore, but the fluid collection is still there? Well, in that leak type in particular, it is very, very important to get rid of that fluid collection, because the longer that a patient lives with a chronic ventral leak, the more exposed they are to a chance of developing what's called superficial siderosis. This is a chronic bleeding through that hole. That blood will seep and diffuse through the CSF, deposit on the brain and spinal cord, and eventually cause a separate, irreversible neurologic condition. And now, the risk of this happening is it's very slow, something like 10% chance for 10 years. But if you have a young person, for example, who developed the CSF leak, and we patch them and they're all better clinically, but they have this fluid collection, we say we need to get this thing totally closed, because if you develop this other disease which is debilitating, then that's a big problem. Now, in lateral type leaks and fistulas, it's exceedingly rare to develop superficial siderosis. So it's a different sort of conversation, but it's always framed around the pictures and you. Both things I want to be better. And understanding that particularly the clinical part can take time. We sometimes have to deal with rebound high pressure, manage that for the patient. There could be this sort of, vacillating up and down over the months to come. Another reason why we can't just do a patch and see you later, because if they go back to their primary care physician, they don't know how to manage somebody's rebound intracranial hypertension. And then back the patient is on social media trying to figure out how to take care of their body with no guidance or information. So we're seeing our patients, long after treatment, making sure that they have a soft landing, or getting them to a place where they can sort of navigate this very tricky period.
Yeah, and you made a good point too, because a lot of our patients are younger, right? So we do, in many things we do and how we treat, we do want to think about the long term, right? Decades from now, really, because we have to keep that in mind. So, Linda, I don't know about you, but I feel like my CSF pressures just increase a bit by all the knowledge I'm gaining. So, it's wonderful.
Yeah, very much so. And I'm curious to ask because, for me, when I was doing blood patches, it was not difficult because you knew where the person did the block or the epidural. You knew what level you were at. So you would go one level below and it was not, rocket science. And I was taught the same thing. If it's getting close towards a week, it's probably going to resolve within a week and then you don't have to worry about it anymore. So maybe you're not even going to patch that person. When you gave that example of somebody who had a Bern score of 0, so you're not expecting that on myelogram you're going to find a leak, which I'm so glad you explained that the way you did. That was very helpful. So in that case, and you said that doing a blood patch would be a reasonable thing, how do you decide where to do the blood patch?
Yeah, it's a great question. I want to touch on one thing you said, just to harp back on the sort of post-stroke puncture headache thing, because I think it's very important that we clarify something. And I think it's particularly, in your world and your specialty when it comes to labor epidurals, right? So a big study came out on women developing headaches after labor epidurals. And, I repeat this statistic frequently, but of the around 3 to 4 million women a year who get a labor epidural, and of those women, 1 to 3% of them have a recognized accidental dural puncture or wet tap. 30% of those women will go on to have a new chronic headache syndrome. Okay. And so telling people, this is the dogma. Oh yeah, just lay down, wait a week, and then, oh, well, it's too long. We'll just want to telling them to ignore this. You're a new mom, you're stressed out, you have headaches. And we find things in these people and can help them. I mean, it's not just like there's this idea that there's a leak or maybe it's something else, not everyone, but someone should be immediately treated. Now, there's some data from the anesthesia literature that patching on the same day as a puncture can be less efficacious and increase the chance of arachnoiditis. But if you're a day, 2 days after, 3 days, a post-stroke puncture headache is technically classified as 72 hours after a puncture. If you're 3 days after, they still have a headache, they need a patch. And it's just, I think that there's this incredible problem with this subset of medicine, and particularly these new moms who are already dealing with so much that they just sort of get kicked to the wayside as well. But to get back to your question, so when I have somebody, for example, with a Bern score of 0, I've had positive myelograms with a Bern score of 0, but it's a minority, right? But we've decided, let's say, together through sort of shared decision making, et cetera, or potentially we elicit in their history that they did have a dural puncture at some point in their past. And it's very interesting when you talk to patients; they don't associate the two. And we know that that chronic post-stroke puncture headache can sort of wax and wane. They can go through a period of normalcy and then it can develop. And so it really skews the clinical interview process and sort of our thinking. But if I'm just going to start with that patch, one other thing that I incorporate is a study that we did with Stanford. So with Dr. Carroll, I partnered with him. We looked at his data, looking at patching patients who are non-ICHD3 positive. So people who had a negative brain MRI, let's call them Bern 0. They had a negative myelogram. But there was no other explanation for their symptoms, and offered them patching and followed them with standardized health metrics over time, over years. We found that there was a large subset, over a majority of the people actually improved, and in clinically meaningful ways, capital C, sort of that defined clinically meaningful by these standardized health metrics. And there was a pattern to those who improved. It was those people who tended to get closest to absolute 0 when flat in their symptom severity. So not how much they could drop down. They started at 10 to go all the way to a 3. Doesn't matter where you start, could you get to a 0? There was a pattern in responsiveness, and the effects were cumulative with more patching. So those two things told us they argue against a placebo response, for example, right? With a placebo, there should be a pattern to who's responding, and the effects should not be cumulative. In fact, they should diminish with repeated intervention. So I use that sort of heuristic, that metric, when I'm talking to patients, and I say, so there's no evidence of it on your imaging at all. Maybe you're young. I don't want to expose you to this radiation, et cetera. But they're like, but I go to 0. Well, like if I'm flat, maybe it takes me 30 minutes or an hour, 2 hours, but I'm basically near symptom free. Then I say, well, let's try a patch. Let's do it. There's a lot of different ways to do it. So, one way, I think in the community, or sort of most ways that somebody would get a patch is in the lumbar spine, one needle under X-ray fluoroscopy, put some blood in there. I found that is not the best way to do it. So going back to that study we did about how patches spread, we looked at the spread to volume ratio. Okay, so we know that if you put more volume in, it's going to cover more spots. It's going to spread up there. But how much does it spread actually depends on where you put it in the spine. So if we think about somebody laying face down, they have that cervical lordosis, it kind of bends forward, then the thoracic kyphosis, like a little hill, and then the lumbar lordosis, like a little hammock, right? I put the blood in the hammock down in the lumbar spine, it's just going to pool there. Turns out if you put it at the top of the thoracic spine, it really spreads a lot for even a smaller amount of volume. And almost all the leak types tend to occur in the thoracic spine. So, in general, I will try to put, I'm trying to get 20 cc's in a blood at least, because we know that from literature is sort of the gold standard for that the magic number that we're trying to get. And I want to get some blood to spread up and down the spine. So I will generally, this is not a one size fits all, one needle somewhere in the thoracic spine. Now, I don't want to go way up in the spine because the higher up we go, the more risks there are in terms of hurting the cord, the spinal cord, or the epidural space is smaller. But I'm doing all these things under CT. I know exactly where my needle tip is. There's no guesswork. And so, one needle in the thoracic spine, one needle in the lumbar spine. This both spreads the patch very well. Also, it hurts less for the patient, I've found, to not have all that volume in one spot. And that would be like the sort of baseline vanilla sort of empiric patch. But then, of course, there's gray areas, right? There's what we call soft targets. So let's say somebody has a nerve root sleeve that looks very unusual. It's a very big, irregular nerve root sleeve. And we're like, is that a nerve root sleeve? Or is that actually the herniated arachnoid pouch that we were talking about earlier? Perhaps I'll target that. Even though they've never had a myelogram, I'll do a patch transforaminally in that area, coat that area, right? And so kind of imaging informed patching, but not there. We have not done a myelogram to prove that it's there. But that's it. I'm trying to sort of balance this. Like, I don't want to do something risky for the patient. I don't want to, do something without evidence that could hurt them. But also, don't have a better explanation for what's going on with their symptoms and want to help them as much as I can. And so it's that balancing act that will sort of inform exactly how we're going to approach a patch in any given patient.
We're lucky to have you taking such a thoughtful approach to these complex problems. There's so many patients that are frustrated. Their imaging is being reported as normal, and their clinicians maybe even don't know what to do. So if their initial imaging is, quote, reported as normal, what do you think patients and clinicians should do if they have these symptoms and they still strongly suspect a CSF leak?
Yeah, it can be very, very challenging, and I really appreciate the kind words, but this disease is a horrible disease, and there is no better feeling, and you feel like Superman when you help somebody. But there's a lot of times where I can't help people, and it's devastating, right? Even me looking at their imaging, doing the patch like I just described so far, and I can't, right? I'm not a miracle worker, and I'm so much less certain of myself and my knowledge now than I was 4 or 5 years ago in terms of what I've seen and the way things that have challenged my preconceived notions. In terms of imaging, there's been some really important studies that have come out recently to further delineate and modify our pre-test probability about somebody having a leak other than just a brain MRI. So, for example, there's a study done looking at the spine and said those meningeal diverticula, these little outpouchings along the nerve root sleeves, we know these are where the fistulas like to occur. If you go looking for fistulas in people who have normal brain MRI, does the presence or absence of those diverticula help you at all? And it turns out it does. So in that study, they found those fistulas in about 15% of those patients, but in 0% in patients who had no diverticula, right? This is very helpful. So it's like one more piece, right? But a lot of people have at least one diverticula, so that's not perfect either. Another thing is the orbits. So getting an MRI of the eyes and looking at the optic nerve sheath. Okay, so the optic nerve goes back from the eyeball to our brain. It's sitting in this tube called the optic nerve sheath, and there's CSF in there. And that's sitting in soft orbital fat, and that's very responsive to changes in pressure. And a study came out that showed that if those sheaths are too narrow, and there's not enough fluid in there, the chance that we're going to find a CSF leak is actually much higher. So, and that MRI of the orbits is a routine MRI that's done at every MRI ever. And so, I can't be there to look at every patient's brain MRI who's it's being written as normal. But I think tips for the clinician, I would say, when you write the order and you're thinking about it, I would write in the requisition, please calculate the Bern score. Okay. Now, there's a lot of stigma around the Bern score. It's like, well, I got a low Bern score. They're not going to, but it at least forces the radiologists to look at these things, right? And maybe they're not looking at it in the best way. They haven't looked at a bunch of them, but instead of many radiologists will just look quickly. If there's no dural thickening or enhancement, no leak, move on. So that's a very useful thing to advocate for your patients. And then you order an MRI of the orbits. Please calculate the optic nerve sheath diameter. And these are, and there's published peer-reviewed science showing that if these diameters, so these sorts, and then that clinician can say, okay, I'm going to take that number, I'm going to go look at this paper. They said if it's below this, all right, I've built a case now that I think that I should send this person to a place where they could get help, or maybe advocate for them to get a blood patch locally that might help them. I can't tell you the amount of times that I see people, we talk about all these complex things, these subtle things, people who just need a blood patch, people who just, uh, had a wet tap and labor epidural, and no one will give them a patch. And it's just, can we transfer them to your hospital across state lines so you could do a blood patch? Like, just do a blood patch. I mean, maybe they need to see me eventually, but why are we denying these people care? And so I think that being able to create the case for your patient in these ways by sort of, these adjunctive imaging tests, literature-based, evidence-based ways gives your patient the best shot, even if the radiologist reading it isn't a leak expert or whatever you want to say, to at least kind of get some clues.
Oh, that's so helpful. And are you saying that the brain MRI and optic nerve sheath MRI and then the whole spine MRI, you order all those together at the same time?
Yeah. So the for somebody who's, let's just call it like, a patient in the community, like whatever that means, but outside of our practice, who's has access to routine sort of medical resources, but not specialized ones, right? Um, in general, it is easy to get an MRI of the orbits, the eyes, and an MRI of the brain. These are routine studies that are performed all the time. Now, it's also easy to get an MRI of the spine, but like I mentioned, we like to get this very special set of pictures, this protocol that's the CSF leak protocol. So, I don't say to patients who want to come to our program, well, you can't come here unless you've had an MRI CSF leak protocol. We'll just do it when they get here, and you could see some things on a regular protocol just fine. But but yes, I would order, if I was a clinician, a primary care physician, a neurologist, and I suspected this, I would order those three sets of studies. Low risk, potentially high reward. Build the case for your patient, or maybe discover something that is pointing you in a different direction, or allows you to have that counseling conversation. We have built a protocol when patients come here where it's not a whole MRI of the orbits and then a routine MRI of the brain, but rather it's like a hybrid protocol where we get pictures of the eyes and of the brain sort of together. So everyone does it a little bit differently.
Well, and we have a lot of clinicians who listen to the podcast. So what you just said is probably going to help a lot of patients because hopefully people are taking notes. And, I just took some notes, so I make sure I order things correctly the next time. So those specifics are so important for us to know because everything's changing so fast. I don't know, Dr. Knight, if you feel the same way, but I feel like, these kind of conversations are just so helpful for us that are seeing people at different stages that are really suffering with so many problems.
Oh, yeah. Totally. Totally. And I'll echo what you said. I'm so glad there are people like Dr. Callen out there to do these things for us because it's certainly above my level of specialty and pay grade and all the rest.
Yeah, I mean, I think that it's, there are so many new things coming out all the time. It's really an exciting time to be in this field. And it's part of what I tell patients who, let's say we hit a wall, like I'm not finding a leak. They're not getting better if I patch them, but there's no other explanation. I don't say, you're done, we're done, see you later. It's not a leak. I'm not your doctor anymore. I say, look, right now our tools are not helping you. But every single week, there is a new paper about this way to do the myelograph, that way to do the blood patch, this MRI to perform to help us find something. And so just sit tight, right? I'm still your doctor, but we're just putting things on hold because we're not getting anywhere with these levers that we could pull. And let's wait for medicine to catch up a little bit. And it is luckily I feel very optimistic, even, if there's patients listening who are feeling hopeless, I have hope for you because the rapidity at which the science is being advanced in this domain in particular, the enthusiasm that radiologists are developing for this disease. I can't tell you how packed the meeting rooms are when we go and talk about CSF leaks at these radiology societies where 5 or 10 years ago that was just not the case. It's a very exciting time, and I think that hopefully for those patients who are suffering, this will eventually catch up in a way that makes a meaningful change and benefit in their life.
Oh, that's amazing news. I love that. And that's, again, why I wanted to do this podcast because there's so many people that they can't afford to come see me, or maybe they can't travel to come see you, or whatever it might be, but they can listen. They're wherever they are, different places in the world. So what you just said, I think, is going to help so many people. Thank you so much.
Yeah, really hope inspiring, I'd say.
Yeah, most definitely. We always end every episode with a hypermobility hack. Do you have one that you can share with us?
Initially, when you had reached out to me, I was thinking about, like, are we going to really dive into the weeds about the hypermobility part of this, which is like, it's really like we could really get into a big discussion about that. Um, I think that patients are, I don't know if I'd call this a hack, but I could say, in terms of my philosophy on the healing process, and somebody who's really worried that this is going to happen to them again. Um, I would say that in this world where there is so much uncertainty, where there is so little good science about what you should or shouldn't do, it is easy to become paralyzed by fear. And sometimes that can lead you, the cure could be worse than the disease. I could patch someone, I could fix them, and they're so scared of it coming back that they can't live their life, right? And I tell patients, you are the expert on your own body, and you need to listen to your body, and you need to, when we feel uncertain, when we feel lost, when we feel untrusted, we try to regain health autonomy by and a locus of control on our health autonomy by blaming ourselves. And I hear a lot of my patients who have a diagnosis of hypermobility EDS or what have you, or who have had a leak and maybe have recurred. I did this. One day I got up and I twisted this way, or I really should have been careful because I read that people with EDS should be doing this or that. I think that we need to, as doctors, shoulder that responsibility for our patients. If your patch fails, it's because the patch wasn't good that I did. You should live your life in the way that you want to, that could bring you joy, and not be paralyzed that everything is going around you is going to tear you apart. Now, everything you're experiencing is real, and there certainly could be. And you'll know, well, if I do this sort of activity today, it's going to make me feel worse. But I would say that what is going on, your own intuition, your gut sense of self, your experience of pain, the way that you're interacting with the world around you, that should be your guiding principle. And not just, well, I heard that people with EDS can't do this, so I'm not going to do this anymore, right? And then those things add up, and now you have a list of 100 things, and you're not getting out of bed, and you have a blood clot in your legs because you're so scared of standing up your patch, right? So I know it's not really a hypermobility hack, but I think that it's just a general sense of trust yourself, trust your intuition, and hopefully we can regain trust with our patients enough that they can stop putting so much of the blame on themselves for the symptoms that they're feeling.
Well, I think that's a great hack. And it's amazing because sometimes I hear from people things that I said to them and they're like, that really meant so much to me. And, we don't necessarily know it at the time. Like I often will say to people, you're stronger than you think you are. Because like you said, they'll hear these things. Oh, I can't do this. I can't do this. And I tell people, you're capable of doing difficult things, and so I love that hack. I think that's a great hack. So I know you're super busy. Thank you so much, Dr. Callen, for taking the time to chat with us today. And I'm so happy Dr. Knight was here, co-hosting. And can you just close by telling us where we can learn more about you and if there was anything else that you wanted to add?
Yeah, no, it was my absolute pleasure. Thank you for having the conversation. I think it's really important to keep getting the word out. And I think if you want to search about our program, you just Google CU CSF Leaks program. You can kind of see what we're about, what the referral process is like. I also would, encourage patients to read scientific articles to see what the peer-reviewed science is. Like I said, there's so much coming out about CSF leaks all the time. A lot of these articles are open access, meaning they're free. The American Journal of Neuroradiology is constantly publishing new papers about CSF leaks, the technology. You could bring these papers to your doctor and say, maybe I'm not the best at reading this, but maybe you could look at this and think about how this might apply to me. Advocate for yourself in a way that is evidence based. And on the other side of that coin, if a doctor seems really sure about what's going on with you and is proposing some invasive treatment or test, uh, go look. Where's the peer reviewed science for that? Because there's certainly an enthusiasm for this data these days, and arming yourself with that knowledge, or at least bringing that to a doctor that you trust, is a great way to do that.
Great suggestions. Okay, wonderful. And you're in my own backyard. I'm going to send you an email after this because I have a patient
I'm jealous.
Yeah. You should be jealous. Well, you could come visit me sometime, and we can both go. We can both go to his clinic because I was actually going to ask if I could do that. If I could come, hang out with you for half a day or something and
Yeah,
watch
absolutely.
you. Yeah, I would love to do that. And I have a patient on your wait list who I'm going to maybe email you about separately. So, but thank you so much for taking the time to chat with us. I know I learned a lot, and it sounds like Dr. Knight did too.
Oh, totally. Thank you so much.
Yeah, thank you both.
Thank you so much for listening to Bendy Bodies. We really appreciate your support. It really helps the podcast when you like, subscribe, and comment on YouTube and follow, rate, and review on all audio platforms. This helps us reach so many more people and spread the information to everyone. Thank you so much again, and enjoy the rest of the episode. Well, that was such a great conversation with Dr. Andrew Callen from UC Health, and what an interesting topic for CSF leaks to be presenting in so many different ways, and people desperately need to get these recognized sooner, and I love all the tips and tricks that he gave us. Thank you so much for listening to this week's episode of the Bendy Bodies podcast. If you'd like to go deeper, I share additional education, clinical insights, and resources in my newsletter, The Bendy Bulletin, which you can find on Substack at hypermobilitymd.substack.com. You can also help us spread the word about connective tissue disorders by leaving a review, sharing this episode, or sending it to someone who needs it. These small actions truly make a difference in raising awareness about conditions that are still widely misunderstood. And don't forget, full video episodes are available every week on YouTube at Bendy Bodies Podcast. As many of you know, I offer one-on-one coaching and mentorship for both individuals living with connective tissue disorders and people caring for them. You can learn more about these options on the services page at hypermobilitymd.com. You can find me, Dr. Linda Bluestein, on Instagram, Facebook, TikTok, X, and LinkedIn, all at hypermobilitymd. As part of our collaboration with the UVA Ehlers-Danlos Syndrome Center, we also want to share some of their helpful resources. For questions or appointment inquiries, you can contact the UVA EDS Center at ruvaedscenter@uvahealth.org. Again, that's the letter R as in Robert, UVA EDS Center at uvahealth.org. You can find answers to common questions at uvahealth.com/support/EDS/FAQ. Our incredible production team is Human Content. You can find them on TikTok and Instagram at Human Content Pods. As you know, we love bringing on guests with unique perspectives to share. However, these unscripted discussions do not necessarily reflect the views or opinions held by me or the Bendy Bodies team. Although we may share healthcare perspectives on the podcast, no statements made on Bendy Bodies should be considered medical advice. Please always consult a qualified healthcare provider regarding your own care. For more information about the Bendy Bodies program disclaimer and ethics policy, submission verification and licensing terms, HIPAA release terms, or to get in touch with us, please visit bendybodiespodcast.com. Bendy Bodies Podcast is a Human Content production. Thank you for being a part of our community, and we'll catch you next time on the Bendy Bodies Podcast. Thank you so much for watching. If you enjoyed this video, give it a thumbs up and leave a comment below. I love getting your feedback. Make sure to hit that subscribe button and ring the bell so you will never miss an update. We've got plenty more exciting content coming your way. And if you're looking for more episodes, just click on one of the videos on the screen right now. Thanks again for tuning in, and I'll see you in the next episode.